and welcome to Preemie Chats, a place for parents and healthcare professionals to gather, share stories, and learn from each other. My name is Jenna Morton. I'm one of 3 co-hosts for this weekly series on behalf of the Canadian Premature Babies Foundation. I'm a career broadcast journalist. I'm mom to 3 NICU grads, 2 of whom are preemies who are now 11 years old. I live and work in Mi'kma'ki outside of Moncton, New Brunswick. Preemie Chats is the creation of the Canadian Premature Babies Foundation. You can see our website there on your screen, canadianpreemies.org. The foundation is a parent-led charity that helps families during and after their NICU time through education, support, and advocacy. I hope that you will take some time to visit the website after our chat today. You'll find the recording of today's discussion, as well as all of our previous Preemie chats, our podcast, all kinds of resources that can help premature families, especially in light of today's topic. Our parent handbook on respiratory illnesses is found there on the website, and I'll put a link to that in the comments later in this discussion for you to find. And speaking of the comment section, please, we would love for you to take part. This is very much a parent-led organization. We'd love to hear from you, whether you are a parent or a healthcare provider, someone else in a preemie's family, maybe you're a grown preemie. Whatever brings you to us today, we would love to know. Let us, drop a note in the comments. Let us know where you're watching from in the world and what brings you to us today. And as we go through today's presentation, if you have questions or comments for our guest, please also feel free to leave them in the comments. And after the presentation, we'll have a chance to take a look and maybe answer some of your questions. Today's discussion features the topic that is very high of mind for many parents this time of year, especially those with preemies. It's a term you're going to hear a lot, RSV, Respiratory Syncytial virus. RSV is a common virus that pretty much every child is going to come in contact with. Many cases are very common. They're not going to cause a lot of extra concern. But for those of us in the preemie world, we know that there's a lot of serious things that can happen if your baby has RSV. And to walk us through a little bit about what it is, what you need to know, and especially what you need to know about it this season as things are ever changing, I'm going to be joined by Dr. Jessie Papenburg. Dr. Papenburg practices pediatric infectious diseases and medical microbiology at the Montreal Children's Hospital of McGill University Health Centre. He's well known in the research world for his work in epidemiology of viral respiratory infections. He actively contributes to national and provincial guidelines on RSV and other viruses, and he's a member of the National Advisory Committee. Welcome back to Preemie Chats, Doctor.
Hi, thanks so much for having me, Jenna.
Well, thank you so much for coming on to walk us through. I know it's always so helpful for us parents to have someone who can walk us through the background of these big words and terms that we hear. And especially, RSV is one that anyone who's just entering the preemie world is probably going to hear a lot about.
Yeah, for sure. And it's my pleasure. And hopefully, I'll be as clear as can be, but I'm happy to take any questions after the presentation as well.
Fantastic. Well, I'm going to turn the screen over to you for your presentation now.
Thanks. So RSV is certainly a virus that we've known for decades, and we know that it's bread and butter pediatrics, and that, as Jenna mentioned, it's a very common infection. But we also know that certain conditions, especially premature babies in their first year of life, or some in their second year of life as well, are at much greater risk of requiring hospitalization. And thankfully, we've had significant advances in the ways that we can prevent RSV, in particular, preventing disease that's severe enough to require a medical visit or a hospitalization. So we're going to talk a little bit about that and make sure that everybody on this call is now aware of what they can do to prevent RSV. So first, we'll talk about what is RSV in terms of its clinical presentation in infants and young children. We'll talk about the burden of disease from the individual's perspective, but also from a public health perspective. And finally, we'll talk about prevention of RSV in infants. So what is respiratory syncytial virus? RSV is a virus that causes cold and flu-like symptoms. So the common symptoms are a runny nose, maybe a decrease in appetite, coughing, sneezing. You can have fever, but high fever is not typical for an RSV infection. You can also have wheezing. So that's the sound that children with asthma can make as well. And RSV bronchiolitis can present with kind of asthma-like difficulty breathing and that wheezing sound that can be audible to a parent, but also audible to the doctor who's examining the child with a stethoscope. One other thing that's not on this list, but that can be a particular manifestation in young infants, in particular premature infants, is apneas. So an RSV infection can cause long respiratory pauses, and that's a more serious manifestation of RSV. So as we were saying, most healthy older children and most adults will get RSV infection and it'll just cause a common cold. But in babies and premature babies in particular, RSV can be more serious, much more serious. In fact, in Canada, RSV is the #1 cause of hospital admission among children in their first year of life. It's probably responsible for about 10% of all hospitalizations of infants in Canada year in, year out. It's ubiquitous. In other words, we find it's very common. Every year it comes back, or almost every year, with the COVID-19 pandemic being a bit of an exception. And we know that about half of all children will have had at least one RSV infection by their first birthday, and almost all kids will have had at least one infection by their second birthday. And it's really that first infection where the risk of the virus going from the upper respiratory tract and just causing cold-like symptoms, going down into the lungs is greatest. So that first infection, when the baby has no prior existing immunity at all to RSV, that's when the risks of a lower respiratory tract infection are greatest. And that can manifest either as bronchiolitis or pneumonia. And we'll talk a little bit about what bronchiolitis is in a few minutes. And on the right, you see some data from Ontario that show that really it's children in their first year of life that have the highest risk of hospitalization. And we talk about roughly 1 to 2% of all children in Canada who will require hospitalization for RSV in their first year of life. So really, it's very common in our pediatric institutions and hospitals everywhere across the country that admit children. So bronchiolitis is a viral infection of the small airways, what we call the bronchioles. We see this in infants, typically in their first year of life, but sometimes in the second year of life as well. Now, the infection in those airways causes inflammation, and that leads to a buildup of mucus. And it's the mucus that plugs the small airways that leads to breathing problems. And that can be respiratory distress, where a child has difficulty breathing in and out, or it can lead to requirements for oxygen, so that this hypoxia can lead to very serious problems if not treated with oxygen therapy. So severe disease is most common in young infants, as we mentioned. So what is severe bronchiolitis, and what are the things that we're watching out for? So first of all, I'd just like to mention that all the management we have for bronchiolitis, all the treatments we have are supportive. And thankfully in Canada, we have access to care so that babies can receive this supportive therapy, whether it be oxygen therapy, intravenous because they're becoming dehydrated because they're having trouble drinking because of all the difficulty breathing they have. And sometimes they can require intubation or mechanical ventilation as well, and ICU care due to their RSV infection. So the things that we see in bronchiolitis, as I mentioned, apnea can be seen in young infants. They'll have cough is very common. When you start having cyanosis or pallor, those are signs, those are danger signs. If you start seeing that there are signs of respiratory distress, in other words, where you see indrawing in between the ribs, or just below the rib cage, that the child is clearly having difficulty breathing, working harder to breathe, breathing faster. These are signs that the child requires medical attention. So we know that there are very specific risk factors or comorbid conditions or underlying conditions that substantially increase the risk that a child will require hospitalization due to RSV. Now, the number one risk factor is actually age. Just the younger the child, the greater the risk of hospitalization. And you can see that whether for a healthy term infant or infants with congenital heart disease, bronchopulmonary dysplasia, or premature infants who don't have those two other conditions, the risk decreases as they get older, and the risk is greatest in the first year of life. Now, you can see that congenital heart disease roughly triples the risk in the first 6 months of life. Bronchopulmonary dysplasia, or chronic lung disease of prematurity, increases that risk several fold. And what's notable about bronchopulmonary dysplasia is that even in the second year of life, it's roughly double the risk that a healthy term infant would have in their first months of life. So that risk in BPD, though these are the babies that are the most fragile from the cardiorespiratory perspective, and really it doesn't take that much to push them over the edge and require some help, whether it be oxygenation or ventilation, that would require hospitalization. And you can see that prematurity without BPD or without congenital heart disease roughly doubles the risk, but that risk is particularly true in the first year of life. But otherwise, healthy premature babies in the second year of life are more comparable to what the risk that a healthy term infant would have. Now, again, these are data from Ontario, and I want to just highlight that even though we know there are these very specific risk factors that greatly increase the individual baby's risk for hospitalization due to RSV, actually, from a population perspective, young age is really the number one risk factor. And in fact, among children in their first year of life who are hospitalized for RSV infection, over 80% had no known underlying chronic medical conditions to explain it. So really, it was just because they were small babies in the first year of life. So why are premature babies at higher risk of becoming sicker with RSV? Well, first of all, you may be familiar with the fact that premature babies, when they're born under 37 weeks gestation, their normal lung development was interrupted in part by birth. So we know that the premature baby's lungs are not as mature as a healthy term baby's lungs. And the lungs will continue to develop over time, but during those first months of life is when this is of particular importance. The second issue is one of immunity. We know that babies in utero will receive antibodies from the mom, so whatever mom has been exposed to in the past, and we know that everybody has been exposed to RSV once they're of childbearing age. So the mother will be able to pass on antibodies to the baby across the placenta. And these antibodies can maybe protect against against getting the infection at all, or at least help prevent the infection from getting down into the lungs. The issue here with prematurity is that it's really in the third trimester, after 35 weeks of age, that the majority of these antibodies get passed on. So premature babies miss out on some of that passive immunity that is offered by this transplacental transfer of antibodies. So these are data from a surveillance or a monitoring program that's been done across Canada, and we were looking at RSV and hospitalizations over 5 winter seasons. And what we found, the key points here, not only did we observe a lot of hospitalizations, but I wanted to point out that among pediatric hospitalizations for RSV, 2/3 were in the first year of life, half were in the first 6 months of life. And that really, if you look within that first year of life, it's the first 3 months of life where the risk is greatest. So really those first 6 months, there's a great risk, but it's really the younger the baby, the greater the risk. And we know that RSV is one of the wintertime viruses. So typically in Canada, RSV is circulated from November to roughly March or April and you can see here that there's a little bit of variation from one year to the next, and maybe a little bit of variation from one province to another within a given year. But in March of 2020, when the COVID-19 public health measures were put into place to stop transmission of COVID-19, what we saw was there was a stoppage of transmission of other respiratory viruses such as RSV. And then we had a very atypical season the following year with a lot of differences in terms of the timing and the intensity of the RSV season across the country. I'm happy to report that the most recent season, the winter of 23 to 24, was much more typical in terms of the number of cases we saw and also the seasonality. Although we still have seen, at least in Ontario and Quebec, a little bit of an earlier start to RSV seasons. We're already seeing RSV hospitalizations in our hospital here in Montreal mid-October. So that's a little bit earlier than usual. How is RSV transmitted? Well, one of three ways. It can be either through direct person-to-person contact, touching, kissing, holding hands, where the virus will then be transmitted to another person, and then that person will touch themselves. They'll either touch their eyes, their nose, and that's the entry route for the virus. Also important are droplets. Droplets are expelled when you breathe, when you cough, when you sneeze. They can travel up to 2 meters, so there needs to be a relative proximity for that transmission of RSV via droplets. And finally, indirect contact. So if an object gets contaminated because, let's say, you coughed into your hand, you then touch something, and then your baby touches that and they touch their eyes, well, that's another way of indirectly transmitting the infection as well. As we know, RSV can survive for a few hours on inanimate objects. People who are infected with RSV usually are contagious for about 3 to 8 days, and they can remain contagious. They can be contagious even before they start showing signs of illness, unfortunately. So before we even know that we're sick and can transmit to others, we can be passing on RSV infection. Typically, children get infected with RSV outside of the home, in school or in daycare, and then they will transmit the virus to other members of their family, especially young babies who may not yet be attending daycare. So what are the things we can do to prevent the spread of RSV? Well, how can you protect your baby, in other words? Is washing your hands often, because that is one of the ways that RSV can be spread. Asking others also to do the same when they're in your house. You can avoid crowds and other young children, especially those that are outside of the family, and especially avoid anybody who has signs of a respiratory infection. You want to try as much as possible, keep toys, clothes, and all that clean. And don't let anybody smoke in your home or near the baby. So we know that smoking during pregnancy can double the risk almost of an RSV infection in a baby. And people smoking in the household also can double the risk. So these are things that we can do to prevent RSV infection in our young ones. So what are the medical interventions that we can do to prevent RSV severe disease? Well, you're probably familiar with Syncytial, known as strictly known as palivizumab, and it's a monoclonal antibody. So in other words, an antibody that really just does one thing. And what it does is it blocks the major protein that's on the surface of RSV called the fusion protein. And that fusion protein, when we get a natural infection to RSV, that's the protein that will develop antibodies against. So this is a synthetic way of administering antibodies to somebody that they don't have to produce themselves. You give them the antibodies in an injection, and Syncytial has been shown to reduce the risk of hospitalization in premature babies, in babies with chronic lung disease, and with a congenital heart disease by roughly half. Now, the specific recommendations for the use of Syncytial vary from one province to another, so it's very important that you be aware of your own province's immunoprophylaxis program. And some provinces are actually now going to move away from Syncytial to newer products. But one of the major obstacles, I would say, for Syncytial is that it requires monthly administration during the RSV season. But we now have a new monoclonal antibody that works in exactly the same way as Syncytial by blocking that fusion protein that only requires one injection at the start of the season, and that will give protection to the baby for at least 150 days. And we know that there's 2 different doses depending on the age of the baby at the first season, either a 50 milligram or 100 milligram dose. And in very high-risk babies who are eligible for nirsevimab in their second season, I don't know if I said Syncytial before, but we're talking about nirsevimab, which is the new monoclonal antibody. It's also known as Beyfortus. So nirsevimab there are also babies that may be eligible for it in their second year of life, and that is a double dose compared to what they might get in the first year of life. So how good is nirsevimab at preventing severe RSV disease? As you can see, it reduces the risk of medically attended RSV, lower respiratory tract infection, and RSV hospitalization by roughly 80%. So really very good at preventing severe RSV disease, and prevents ICU admission by 90%. So those are really very nice numbers in terms of the level of protection it offers. The studies have shown that there's no difference in terms of serious adverse events compared to placebo. And the only thing that we saw that was different in terms of side effect profile was that there were more injection site reactions compared to placebo, but even that was less than 1%. So a very effective and safe product in the randomized trials, the clinical trials that brought the product to approval for use. And there have been other countries that used nirsevimab last year. The United States, France, and Spain are amongst the biggest countries that use nirsevimab, and all of these have shown that nirsevimab is effective at roughly 80 to 90% to reduce emergency department visits and hospitalizations due to RSV. So it's really nice to have this confirmatory information, these studies that have shown when nirsevimab is used in the field, so to speak, it's just as effective as it was in the clinical trials. Now, we don't know how well it works for extremely premature babies born under 29 weeks gestational age. At least I can't give you a percentage of vaccine efficacy or immunization efficacy like I was able to give you before. Those studies were done in babies 29 weeks and above gestational age and healthy term babies. But there was a study that looked at nirsevimab compared to palivizumab or Syncytial. Obviously, we couldn't give extreme premature babies placebo. They needed to receive nirsevimab. And in the United States, they need to receive either the active product nirsevimab or the comparator palivizumab. And in the United States, palivizumab is indicated under 29 weeks. So that's why we have this cutoff here of 29 weeks. But what we can tell you is that in babies with congenital heart disease, BPD, and extreme prematurity, they had similar levels of antibodies that were shown to be protective in the rest of the population that was studied 29 weeks and above and healthy term infants. So really, we expect it to work just as well in these very high-risk conditions. We don't know how long nirsevimab works after 150 days. So after that 5 months, we expect it to still work some, but we don't know how well. So we don't want to give it too early before the start of the RSV season because the effectiveness might wane over the course of the season. So it's been offered. What's going to happen in the places that do offer it, it's given during the birth hospitalization before the baby leaves the hospital, or at catch-up visits at 2, 4, or 6 months of age. Just to let you know, there's another very exciting way of preventing RSV infection in young infants through this passive maternal transfer of antibodies that are generated from giving the mom a vaccine during pregnancy. She boosts her antibody levels. Those antibodies get passed on to the baby, and the studies have shown that the use of this vaccine during pregnancy reduces the risk of RSV disease by 50 to 80% during the first 6 months of life. So In conclusion, I think you can see that RSV burden is substantial, especially among infants under 6 months of age, but certain high-risk conditions keep that elevated risk longer, some even into the second year of life. So infants with high-risk conditions for severe RSV include those with prematurity without any other conditions. We're talking mostly in the first year of life that they're at risk, but then babies with congenital heart disease, and especially those with chronic lung disease, that risk persists into the second year of life. There are everyday things that we can do to protect ourselves from RSV. A lot of those things we already kind of learned from the COVID-19 pandemic. We know that monthly injections with Syncytial are available in many provinces for very high-risk babies. So you need to know what your province is offering, because in Ontario and Quebec, we are now offering the long-acting monoclonal antibody nirsevimab to all healthy term infants and to our high-risk infants as well. I know that BC has a targeted program for some high-risk infants, so it's important that you look at your province to know what is being offered so that you can avail yourself of it for your baby. Maternal vaccination is also approved for use in Canada since 2024. It's free of charge in Ontario, but it's out of pocket in other provinces for now. So these are some useful resources from Immunize Canada, the Canadian Premature Babies Foundation. There's also RSV Shield, where you can see some things, and also the CDC, Centers for Disease Control in the United States, has some information for parents as well. So I'll end things here, and I'm happy to take questions at this point.
Well, thank you so much for that presentation. I'm always in awe of how you can take such scientific data and make it sound so relatable for parents. So on behalf of all of us who are out there going, oh, not more, scientific details, you really help bridge that gap of here's the science why in words you understand.
Thanks. I appreciate that, Jenna.
I think, it's so exciting as a parent who went through RSV season with preemies. My boys were born in February, so we were right in the thick of an RSV season. But it was 11 years ago, so we had to go through those cycles of having to come back in and get more injections, and to think that we're coming to a place now where there might be a single injection, and there's something that mothers can do while they're pregnant to feel like they're helping their children it's still so exciting.
Yeah, it's, for years we've been talking about how there were new preventive measures that were on the horizon for RSV, because all we had was palivizumab since 2002 in Canada. So decades of palivizumab use. And we were hoping for new products that would be easier to administer, that would be less expensive, because palivizumab is extremely expensive. It can be average about $5,000 per season per baby. Now, it's not to say that nirsevimab is not expensive. The list price for that long-acting monoclonal antibody is $950, but I know that provinces were able to negotiate lower costs than that, but how low is not publicly available. But all that to say that we've been waiting for this for a long time. And it's just finally appeared since 2023. Nirsevimab was approved, and just this year, RSV vaccination in pregnancy was approved for use in Canada. So it is very exciting. And I find it also exciting that even though the RSV vaccine for pregnancy and during pregnancy is not publicly funded in most provinces, we are giving pregnant families the option. It's at least available commercially, and people can choose, that if they want to get vaccinated during pregnancy to protect their baby, they can do that. And not all provinces have a nirsevimab program either, but we're hoping that eventually across Canada, there will be in place programs that are free of charge that will include either nirsevimab or the maternal vaccine or a combination of both. And it's really exciting. Now, I think one thing I want to point out, obviously, parents of premature babies, the vaccine during pregnancy is no longer an option because the baby's already delivered. Then the other thing to note about the vaccine during pregnancy is that if the baby is born prematurely, then we don't consider that the baby was sufficiently protected from the vaccine. So they would then be eligible also for the nirsevimab injection in a province that if it is available. So that's one little wrinkle. But I'm curious to see, as this year unfolds, in a province like Ontario, where both are free of charge, nirsevimab is preferred because it seems to work a little bit better. The numbers in terms of the efficacy in preventing disease may be a little bit higher for nirsevimab than it is for the vaccine. But I'm sure there are some families that will choose the vaccine, and there are some families that are going to choose the monoclonal antibody after birth, and it'll be interesting to see how those numbers break down, and what Canadian families want choose, how to protect their babies from RSV.
I think that data that gets gathered over the next, 2 to 3 years of RSV seasons will be very telling in trying to understand, how this is impacting, like you say, that burden on our healthcare system, which is really what will help make the case for more and more provinces to be able to offer this to families, is when you can show those hard numbers of, how many babies you're helping keep out of hospitalization in those first, like you said, 3, 6, 1 year, 1 month of 1 year of life. Sorry.
Yeah, absolutely. I expect in Quebec, if the uptake is as good as it has been in some of the European countries where nirsevimab was offered, so the long-acting monoclonal antibody, in Spain, it was 80 to 90% of infants did receive nirsevimab among those that were eligible. The 90% was for babies that were born during the RSV season, so when they got the injection during their birth hospitalization. So there's that opportunity to educate and vaccinate during the birth hospitalization. A little bit lower, 80% in babies that had to do the catch-up because they were born before the RSV season. So getting a dose at the start of the RSV season, there's a little bit, there's that additional step of having to make it to whatever appointment it is that your system has to offer vaccines. That perhaps was the difference, that 10% difference. But if we do see that in Quebec, that 80 to 90% uptake, I think in our hospitals, our pediatric hospitals, we will feel the difference in the numbers of cases that we have to treat. Because, if it does indeed, if we have 89% of babies that get it, 80, 90% protection against hospital admission, that's a lot of hospitalizations that we are going to prevent. And I think we're gonna notice it.
Yeah, it must be such a kind of elating feeling for healthcare providers to have this on the horizon and think what might come.
Absolutely. And people who've been working in the field for such a long time, it's what we've been hoping for, is a way to prevent severe RSV in all babies, our high risk babies, but also other healthy term babies, because they too can get into trouble with RSV.
Yeah, we do have a question here, and it kind of touches on that idea of the extra step in a way of, this parent is asking about, a baby who's 6 months old now. Can they get the RSV and flu shot and DTaP all at the same time? And, and I know as a parent, that's always like, okay, how much can we do at once? And do certain things need to be spaced out from each other? What can you say around that?
Right, that's a great question, and I think there are two parts to it. One is, can we give the monoclonal antibody to infants at the same time as other regular new infant vaccines, so part of the regular program, whether it be the Tdap or an influenza vaccine? And the answer is yes. They really work in different ways, right? The monoclonal antibody, the antibodies are preformed. And we're just injecting the antibodies, whereas these other vaccines that are the more typically what we think of as in terms of vaccines, and that's true for influenza or all routine childhood immunizations, is we're showing either a part of the virus or bacteria that we're trying to offer protection to. or a modified version of the virus that's really so weak that it can't cause a disease. And by seeing this part or part of the virus or part of the bacteria, the immune system is then able to recognize it and it offers protection that will prevent disease later on. Whereas, antibodies they're just there for as long as they stay there, but they're gonna wane over time as the antibodies kind of degrade as because the baby's not producing them themselves. So these are two different mechanisms, and we think that it's not only it's safe but just as effective to give the nirsevimab at the same time as other routine immunizations. Now, at 6 months of age, if he's 6 months of age now, I think it'll depend on if he's in a province where there is a nirsevimab program. I believe that in Ontario, it's any child born in 2024 would be eligible to receive nirsevimab at the start of the RSV season, which has been decided to be November 1st. And in Quebec, a little bit more complicated. In Quebec, it's under 6 months of age at the start of the RSV season if they're otherwise healthy. If they have a risk factor, it can go up to 8 months of age at the start of the RSV season. They'll be eligible for nirsevimab. And that really has to do with the fact that we know that the risk is greatest in the earliest months of life, and you get less bang for your buck, so to speak, as the child is older. There's less risk after the first 6 months of life of hospitalization. So that's why Quebec has got that schema in place. Ontario is a little bit more liberal in terms of who can get it in that first year of life.
Well, and our question came from someone who's in Ontario, so they're in the lucky group for that. But on that point, if someone's watching from somewhere else in Canada or even somewhere else in the world as a parent, and they want to ask their healthcare provider or find out information that would pertain to them, what are the steps that you can suggest for them?
Well, you can look on the internet. In particular, the Canadian Premature Babies Foundation has a list of the indications for RSV prevention, whether it be Syncytial or nirsevimab by province, or links to the provincial programs. So that's one way. If not, speak to the nurse who's responsible for your child or a doctor who's responsible for your child to see if they are potentially eligible. The criteria for Syncytial, so for the provinces that have not yet moved to nirsevimab, the criteria tend to be stricter for Syncytial. It's such an expensive and labor-intensive intervention with the monthly injections that it's really only the highest risk babies that get it. So those criteria in terms of how premature the baby needed to be at birth will vary from one province to another. So it's important that you speak to your healthcare provider. But I would say that most babies that are born with these types of conditions, often healthcare providers will have spoken to them about a prevention for RSV, mostly Syncytial in most parts of the country, but perhaps nirsevimab if you're in Ontario or Quebec. And so these are the things that we're talking about. But if you're unsure, just go ahead and ask, and then you'll get the right information.
Before we wrap things up, but we don't have any other questions coming in at the moment, I'm wondering if you could just take a moment to again remind people, because it's so important, of all the steps that we can take to try to help prevent infection in the first place. Because we know that this is something after the last couple of years, I think the general public is more interested in RSV season than they have been in the past. And a lot of those families don't qualify for some of these medical interventions. So a quick reminder on what we can all be doing.
Right. So as you pointed out, that first, see if your child is eligible for a preventive intervention like nirsevimab or palivizumab. And whether they are or not, there are things we can do to prevent RSV infection. So One is frequent hand washing, because we know that there is that transmission through contact with RSV. The other is avoiding exposure to people who have any sort of symptoms that could be common cold-like symptoms. It might not be severe for them, but it could be very severe for a young infant. Avoiding crowded areas as well, as much as you can, especially, I think, the more premature the baby was born, the more medical complications a baby has had, I think the more careful we want to be. And I don't want people to lose their minds either and try and live, as hermits. But I think that there are things we can do, especially when there's a lot of virus circulating. And we know it's starting now. If there is a caregiver who has to look after a child who is sick, in addition to washing hands, they can also wear a mask to help prevent the transmission of RSV. We know that daycares and childcare settings are frequent first exposure for RSV for young infants. So now I understand that not all families have the option of not sending their child to daycare or childcare. But again, the more premature, the more complicated a medical history a young infant has, I think the more we have to kind of consider trying to delay the introduction to childcare, because the older the child is when they get their first RSV infection, the better they'll be able to handle it. So these are some of the things that parents can consider. Some of the things that they have at their disposal. And like I said, I realize that not everything is going to work for every family, but there are things that we do have in our control to try and reduce the risks.
One last question, because I realize we've talked a lot about the start of RSV season and that we're getting into things now. What do we consider to be the end?
Well, typically the end would be the end of March, but sometimes that gets adjusted a little bit according to that season's epidemiology. We've had some years where the season has finished early and public health officials decided to stop giving Synagis earlier than usual. And we've had other seasons where the season has lingered on and we've given additional doses of Synagis to high-risk infants later on. But generally speaking, we're talking about from the beginning of November to the end of March.
Perfect. Thank you so much, Dr. Papenburg, for joining me today to talk about this.
It's been my pleasure.
And thank you to everyone who's been watching and following along with us today. My guest was Dr. Jessie Papenburg, who's a pediatric infectious disease specialist at the Montreal Children's Hospital. And you can watch this presentation again on our website, on our social media channels. You can share it with someone who you think should also benefit from this information. And of course, you can find all kinds of resources on our website there as well, canadianpreemies.org, including the handbook about various respiratory illnesses and lots of information specific to RSV. I'd also like to take a brief moment to thank our sponsors, Sanofi and AstraZeneca, as well as the Canadian Association of Neonatal Nurses and PhiCare. Preemie Chats returns next Friday at 1 p.m. Eastern, and I hope that you will be well until you join us then.